So highlights of EHA22, I guess there have been some important presentations, some already done and some still to go. I think the one in the indolent lymphoma space, which is very interesting and has generated a lot of debate, is the SHINE data. So SHINE is a randomized international study in the frontline treatment of older patients with mantle cell lymphoma. The standard of care was BR, so bendamustine-rituximab followed by rituximab maintenance, and the investigational arm was adding in Ibrutinib to that. So it's bringing Ibrutinib in combination with chemotherapy in the frontline space. And it shows a significant progression-free survival advantage of around 2.3 years, which in an older patient group is quite substantial. The controversy is around the fact there's no overall survival advantage, which perhaps is not unexpected at this time point, but also there is a significantly prolonged time to next therapy. The reason though why that's controversial is of course the Ibrutinib carries on to progression, so you're already on much longer therapy, so your time to next therapy perhaps isn't such a relevant endpoint because your placebo arm, your therapy finishes at 2.5 years, that's when your rituximab maintenance stops, but your investigational arm, the Ibrutinib, just continues. So time to next therapy isn't a really relevant endpoint when you're on therapy already. So that, it's causing quite a lot of debate. And the question is, is there any benefit in having your Ibrutinib up front? Why not just give BR and R maintenance and at relapse go for Ibrutinib? Because there's no overall survival advantage, that may be actually just as an effective approach, and it's also given your patient a treatment-free interval. So I'm sure this debate will sort of rattle on, and I mean currently, we would not have access to this, certainly in England, and whether this goes through a NICE appraisal, I think remains to be seen. I mean, this trial was designed quite a long time ago, and of course therapies have changed. We've now got CAR T cells available, and of today in England we can still use Ibrutinib rituximab, not with chemo, but just Ibrutinib rituximab up front. It was brought in as a COVID measure and it currently hasn't been reversed. So whether there's an appetite to actually add in bendamustine to that, I think remains to be seen.